got some important data. CDC recognized the problem. Actually, this came out a couple of years ago, and it came out as a consequence of the work that we're doing and the work that's being done in Colorado and the work that's being done in Pennsylvania. Those are the 3 states that have been looking at brain injury in the prisons. So we're proud to be a part of that recognition. So take a look. It's in your folder. So here's I'm going to cut right to the most critical data. Thank you, Wendy. In the general population, 8.5% of us have a history of a traumatic brain injury. 60% of offenders have a history of traumatic brain injury. So, and that's based on 20 different studies. And it varies a lot according to what's happened in your crime. But that's the difference, is 60% versus 8.5. So that means 60% of people in each of your correctional facilities, 60% have a history of traumatic brain injury. And that doesn't include all the other acquired brain injuries that we didn't talk about in any detail. That's just traumatic brain injuries, okay? Now let's talk about kids and pediatric brain injury or adolescent brain injury. To what extent is that a risk factor for incarceration? So this was a beautifully done study of 508 kids that were in a psychiatric inpatient facility, okay, in Finland. So if you had a traumatic brain injury, 54% of those adolescents had a history of traumatic brain injury versus 15 without a traumatic brain injury. Those people that had a traumatic brain injury had significantly more violent crimes, and these are kids and adolescents, okay? The traumatic brain injury during childhood and adolescence increased the risk of any criminality by 6.8 times the probability. So if daddy smacked you around too much in the head, and you got too many concussions, or you got beat up by the neighborhood or kids or whatever, you're 7 times more likely to have criminality. And that's hugely statistically significant. You're 7 or 6 times more likely to have a diagnosis of a conduct disorder because your frontal lobes don't work. You don't conform your behavior to societal rules and expectations and regulations, right? And concomitant criminality and conduct disorder is almost 19 times greater. So this is not a minor issue, folks. It's an epidemic. It's a behavioral epidemic. It's a chronic condition that affects our behavioral stability. Time in criminality, the risk of criminality gets worse over time, not better after a head injury. That's the other paradox. And the reason for that is because of the interaction between these biopsychosocial levels that influence the ultimate outcome, okay? So things go wrong and they accumulate. So the donut keeps getting smaller and the effects of the injury keeps getting bigger. So at 1 year post-injury, 7% have had their first involvement with the criminal justice system. At 2 years post-injury, 24% have their first interaction with the criminal justice system. And by year 5, 31% have their first interaction with the criminal justice system. So why is it? Again, go back to the donut and the hole. So the criminality results from a deterioration from the biological, psychosocial, and the environmental effects of the injury. And so over time, you're at increasing risk for incarceration. 83% had their traumatic brain injury before their very first involvement with the criminal justice system. So when you think about causality, when you think about legal definitions of things like insanity and so forth, the issue is that 83% had their injury prior to criminal behavior. Now, put a traumatic brain injury in a criminogenic family. What's the likelihood that that person's going to offend? I would argue that it's close to 100%. You predict that. Isn't that patient at totally high risk for offending? What if we recruited at Ashkenazi? What if we had, as a healthcare system, identified high-risk people at Ashkenazi and intervened before they committed an offense? I know it's a novel idea, but... So let's talk about the healthcare disparities that exist, and they're really significant. So this study looked at 20 African-American men convicted of domestic violence, and 20 African-American men without criminal convictions matched for age and socioeconomic status, which is an important point here. More than half had sustained a TBI in both groups, but the injuries in the offender group were significantly more. Greater problems with anger management in the and these patients, because they didn't have insurance, had no access to health care or follow-up after their injury, and therefore the prevalence of those kind of difficulties are completely underestimated, or result in us underestimating how significant these problems are across our culture. So healthcare disparities are extremely real as it relates to brain injury, and they're not receiving services to manage them. So once you're incarcerated with a TBI, you have significant higher rates of infraction while you're in custody. You have higher levels of reoffending once you get out. So you're significantly more likely, if you screen positive for a brain injury, and your crimes are likely to be more violent. Inmates with a TBI have been found to have significantly greater risk of violence and self-harm. So you're more likely to attempt suicide or have completed suicide, or you'll be aggressive with others. The most aggressive people in your system are people with major depression, a history of traumatic brain injury that affects frontal lobe function, and a history of substance abuse, which just further compromises the brain, the donut, the healthy brain, its ability to compensate for the injury. Those are the biggest risk factors you have in terms of affecting stability in incarceration and at release. So if you release someone with frontal lobe injury, substance abuse in the past, or substance abuse that you know they're going to use, and they have major depression, the likelihood of them reoffending is huge. And the greater the impairment of executive functions, we'll talk more about what that is exactly tomorrow, but executive functions, again, are those mood regulation systems, part of it. The greater the damage to that part of brain, the worse the aggression is. So in violent inmates that had a history of childhood and adolescent TBI, well, let me back up. So many people that get incarcerated don't have good school adjustment, or a good history of good school achievement, or a history of good school adjustment. That's true. But if you look at those individuals with TBI, they have significant more history of violence and difficulties with adjustment in the prisons. It's not, and the point of this study was to say it's not a conduct disorder that leads to the prison adjustment difficulties. It's the presence of the traumatic brain injury that results in the conduct disorder, and it's not the history of learning disabilities or pre-existing conduct disorder. In this study, 100% of inmates on death row have a history of traumatic brain injury, and in another study I saw 100% of women on death row specifically demonstrated a history of traumatic brain injury. So thanks to judges present in this audience, thank you very much, we were able to screen in the Marion County problem-solving courts. And this had a major impact on this entire project, folks, so thank you very much. We screened 187 people in your courts. Took place between August and October. We looked at the women's drug treatment, men's drug treatment, mental health, heat, parole, reentry court, and veterans court. Here's the data. So in women's drug treatment, we had 53. 9.4% had moderate to severe, so 1 out of 10 of your people has got a moderate to severe head injury. 60% had mild to severe. 40% of those were non-traumatic, so things like stroke, anoxia, getting choked to the point where you pass out, okay? Infections of brain, so forth. Men's drug treatment, we had 41, 2.4 screened positive for moderate to severe, but 50%, 46 with any brain injury. 42% were non-traumatic. Mental health court, we only had 13 in there, subjects, 0 with moderate to severe, but 77% screened positive for mild traumatic brain injury. 40% of those were non-traumatic. Heat parole, we had 15, 6.7%. Only 33%, interestingly, for any level of brain injury, and 27% of those were non-traumatic. Reentry court, 44. We had a sample of 44 there, which was great. 10% screened positive for moderate to severe, 11%. 55% overall, including mild. 25% were non-traumatic. Veterans court is 95% screened positive for any level of brain injury. 9.5 for moderate to severe. 91%, actually that got reversed. I'm sorry, that should be 9% were non-traumatic, sorry. So a total across courts, we have 7.5 with moderate to severe head injury, but 60% with any level of brain injury are coming through your courts on a daily basis. So I don't know how that stacks up to other kinds of medical conditions, but I suspect it's pretty high. So that's the data just in another way. In injury severity, 60% are mild, and 27%, sorry for the 27% overall are, I believe that were, 13% were moderate to severe, and 27% were non-traumatic injuries. So, when we analyze that data statistically, the Veterans Court clearly shows a very significant difference in terms of the prevalence of traumatic brain injury, 0.05, as well as looking at overall incidence of acquired brain injury, which is 0.05. There's no other difference between courts in terms of rate of traumatic brain injury. They're all essentially comparable across different courts. When looking at moderate to severe rates only, there are no significant difference between courts. Only when you include mild head injury, that's when the Veterans Courts jumps to 95%. So it's a problem across all of them, but especially for the vets. So why are some people at more risk? So we'll get into this in more detail, particularly tomorrow morning. But if we look at these different, I'm talking about executive functions and orbitofrontal functions of the brain. And I want to dig a bit deeper to this. So this is a CT scan of a patient with a frontal lobe injury. Those white areas up there are what are called hyperintensities on neuroimaging. And this guy got whacked in the head. In fact, he hit his head on a telephone pole. He was riding his motorcycle, flying through someplace, and flew off of it and went straight into the telephone pole. And has these contusions or bruises. This is blood has a higher intensity than brain tissue. And so he's got these bilateral frontal lobe contusions that are right here in the brain. So the frontal lobes are decidedly involved, as we've said, in regulating human behavior. If you examine this guy, his physical capacity is perfectly fine. He has no weakness in any part of his body. His speech is fine. He can tell you what day it is. He can tell you what it is. He's fully oriented. There's no obvious physical disability whatsoever, but he presents with significant behavioral changes. The characteristics associated with this injury include disinhibition and impulsivity. In the literature, prior to our understanding of this, they were described as pseudo-psychopathic in nature. So these folks are doing things they shouldn't be doing. They're breaking rules that they shouldn't be breaking, and they know that they shouldn't be doing that. They're often hyperkinetic, that is, they can't sit still. If you watch, they're just constantly moving. They have a lot of difficulties staying on task. They shift from one topic to another. And they're often jocular when they shouldn't be. They'll be making jokes in front of the judge when they shouldn't be making jokes in front of the judge, or they're saying things that are sometimes sexually inappropriate. Sometimes they can't inhibit touching sexually or reaching out in ways that they shouldn't. They'll shift. They'll be euphoric at one moment and then irritable as heck the next. And these injuries are associated with damage to the frontal lobes, particularly at the poles here and on the basilar surface frontal lobes. So, and from a cognitive standpoint, these patients they'll be able to start figuring problems out or solving problems, but then they can't stay on task. They move off task, and their persistence is poor in that respect. Because of the euphoria and the irritability and the aggression and then intermittent depression, many of these folks are diagnosed as psychiatric disorders because that's exactly what they look like. And the person doing the diagnosing doesn't know that they have a history of brain injury. And so that's the appropriate diagnosis to make when you see those kinds of behaviors and you see that in the history. But if you know that patient's had a brain injury, of course, then you have a significant shift needs to be made. So as I said, this project is focused on trying to decrease the return to incarceration, decrease in rearrest, and an increase in employment. So what we're doing is particularly through this conference, we had a conference last year. The first objective is we're trying to get people to screen. and there'll be a presentation. I think that's later today. Claire, is that right? Yeah. Later today, and some of you have had that screening already, but we want you to know how to do that, because that's the first stage. And I think we also have, and maybe we have people online. So our healthcare provider through the DOC, I think it's particularly important for you guys to have that opportunity to learn how to do the screening, to identify folks and head them towards a more appropriate diagnosis. We're also going to have a case study of a patient that came to us through this project that we've now had the opportunity to evaluate, but this patient came to us through, I think, Judge Serto's court, or maybe, I'm not sure, but through one of the courts, this patient was screened positive and came to us for a follow-up. But the issue is screening for these people, and as I said, right now we've been doing that starting with the Duvall Work Release Center and also through PACE. And then also we adapted the Ohio State screening instrument, which is what we're going to train on this afternoon, to include acquired brain injury so that it captures all of those folks. And so that was an important change we wanted to make. And what we're now doing is we're starting to refer these folks that screen positive to different resources that they can access. So throughout the state of Indiana is pretty unique in this respect. There are at least now, 16, I think, brain injury. How many brain injury support groups are there in Indiana now? I think it's maybe 16 or 18 throughout the state. And we're getting people referred to those entities, which are really important. And we've developed a variety of educational materials, some of which are in your folders. And also, please take a look at our website, which is referred to in there. Take a look at your packets. You also have one that is a listing of all of the fact sheets that we have developed on brain injury. I think it's on the right side of your packet. Yeah, brain injury fact sheet catalog. So these are all available online. For example, brain injury and alcohol, brain injury and impulsivity, brain injury and managing emotions, brain injury and post-traumatic stress disorder, et cetera, et cetera, et cetera. So there's a fact sheet on the website. You can download them as PDFs or whatever you want. But anyway, these are all materials that we've developed for you through the process of this grant. So year 2 is when we started then educating correctional staff and started beginning to establish the methods that we would use to evaluate outcome. We've now screened, actually in year 1, we screened 1,400 people through the parole district. 13% of those folks have been showing a moderate to severe brain injury coming out of people years 2 and 3. 12% of those people are, and we've decided to target moderate and severe brain injury in the grant because we think that there's a greater chance that we can make a difference for those people with moderate severe injury. So again, 12%, that seems to be holding true. And then we developed a series of brain injury modules for the Department of Corrections staff. We can make these available for anybody. They're short modules on brain injury education. Superintendent Osborne got 6,000 DOC employees trained on those, which I think is huge. And so then what we did was based on the screening that we did in your problem-solving courts, and this rate of 95% of veterans, we made the quick decision to now bring services into the Edinburgh and Putnamville prison. Of course, we'd like to do that throughout the state, because we know 60% of the people in all the prisons are going to screen positive for brain injury. But so what we're doing in those entities is screening. We've been teaching the staff to do that. Those people then come to us for some brief neuropsychological testing. And now for the first time we're also giving them a brain injury coping skills group intervention. So this is an evidence-based treatment focusing on, okay, now that I know that I have this brain injury, now that these are tools you can use for managing your memory impairment. These are tools you can use for managing your emotional dysregulation problems. These are problems you can use, or these are strategies you can use to help get back to work and the like. So we're beginning to bring those services into the prison so that those folks can access them pre-release. This kind of group intervention's also been available through PACE, or a version of this group is available for the ex-offenders as they're coming through PACE, so that hopefully they can begin to get some tools in dealing with their injury. But then also in the Department of Corrections facilities, then this lays the stage then to hook these patients or these ex-offenders with brain injury up with resources in their community. So when we have this conversation about, okay, we screen them fine, what do we do with it then? What's the next step? And you know, so we're just scratching the surface on this, folks, and we've got a long ways to go. And I hope that in the panel discussion this afternoon, I hope that we can address this further. What I can tell you that we're doing so far is that some of the people have been able to then get into what's called resource facilitation through the rehabilitation hospital. And resource facilitation is funded by the state vocational rehabilitation agency. And so, for example, the patient that Judge Serto is court screened, this patient has now come into resource facilitation, and she's going to be the case study that is done later today to show how the system can work. The problem is that the number of patients or number of ex-offenders don't get into Indiana vocational rehabilitation. So what do we do about that? That's a larger issue. And for that, I don't have a solution to the extent that it needs to be. But let me just quickly describe resource facilitation for you so that you get a picture of what that is. Resource facilitation was developed for people with brain injury to help them return to work. And basically it is a service and system kind of case management or navigation system. So we'll evaluate someone and help them get access to services and supports that they would access to otherwise. We'll also help them, if they're not signed up on HIP 2.0, we'll help them get insurance. If they're not, if they don't have housing, we'll help them get housing. If they have a memory impairment, we'll try and get them to someone who knows how to manage memory problems. If they aren't on the right medications, we'll try and get them to someone like Dr. Leland, who knows how to put them on the right kind of medications. So what we've found in multiple studies is that instead of the return to work rate being 18%, now our people that get resource facilitation are returning to work at 70% of the time. So that's a very significant difference. But this doesn't promote, this isn't available for many folks if they're not clients of Voc Rehab. So the alternative to this is to get them into vocational rehabilitation when they are released or when they're coming out of your courts. So we have, Wendy, stand up and raise your hand. Wendy is our local support network leader. You can meet her out here at the table. Wendy is someone who will shepherd someone from your referral into the vocational rehabilitation system. We have a local support network leader like Wendy in northern Indiana, and we have one in southern Indiana. And so people can access this service if they get into vocational rehabilitation. So the eligibility criteria for VR in this service is they have to have a brain injury, and if you've screened them, that moves them in that direction, and they have to want to return to work. So if they meet those two eligibility criteria, and you make that referral to the local support network leader, they may ultimately access that service. What we noticed is we're just scratching, guys. I mean, so this is just, you know, we're only doing this now in 2 prisons, and we're only funded for another year. We're only doing the screening at PACE, which is a single reentry program in Indianapolis. We're not doing it throughout the state. So while we're light years ahead, we've got much further to go. We need to get screening throughout the DOC. We need to have a state plan for brain injury specific treatment and management strategies that cuts across all of these agencies, because right now the DOC and VR are leading the charge on this. And so we need to get the other agencies involved in this. So that's, I've ended early here, so that gives us some time for discussion if you want. Or we can take a longer lunch and start a bit early. Yeah.
I take it that
Right, so the location of injury as it relates to frontal lobe injury is hugely important. That is, although with that said, many brain injuries ultimately affect frontal lobe functions, but especially a frontal lobe injury is a huge determinant of your susceptibility to criminality.
Then taking that the next step, what are we to expect from people who have a specific area of brain injury? How can we get an indication about what to expect from them?
So that's a beautiful question, and it's an incredibly complex question. So we'll drill down more on that tomorrow, okay, on the cognitive and behavioral side of the effects of brain injury. But yes, the presentation of brain injury is incredibly diverse and goes from, language impairment to difficulties with perceptual functions to attention problems to memory problems to executive functions. I mean, it's as varied as you can imagine.
Thank you.
Yeah. Yes, ma'am.
Good morning.
Hi.
Bear with me, I have a bunch of questions for you.
Thank you.
I guess this is a beautiful presentation, by the way, but I'm a bit confused because I know that there's a screening tool that we're going to learn about.
Can you speak a little louder?
I know that there's a screening tool that we're going to learn about and learn about how to use it.
Yes.
But if, like, say we direct someone to a neurologist, if a neurologist cannot see a brain injury on a CAT scan, an MRI, the neuropsych testing, how do they know there is a brain injury?
Right. So remember, you're screening for brain injury, you're not diagnosing brain injury. So I think that's the first distinction. So we have to start someplace, and the first place to start is to screen. And if you screen positive for a moderate to severe head injury, the probability that you still have a brain injury that's affecting your functioning is really, really high. But the point of the screening is to get people to people that can then diagnose that brain injury. Does that make sense?
Yes.
Yeah.
Yes. And then I guess my next question was, once you realize there's a brain injury, is it antipsychotics anticonvulsants, or what is it that works medically for the brain
Well,
injury?
that's a beautiful question, and that's all what tomorrow morning is about with Dr. Hammond. So she's going to drill down on medications and brain injury because they are decidedly unique relative to psychiatric interventions.
Thank you.
Yep. Sure. Yes, sir.
In your studies, did you limit just to brain injury, or did you actually try to attribute also certain things like autism?
So I'm not qualified on autism, and no, we're not doing that. Yeah, I know that's an issue, but I'm not an autism researcher, and couldn't tell you anything about that. Sorry. Other questions? Yes, sir.
When you did your screenings, especially with the folks in DOC, in the Department of Correction, or when you did it with our problem-solving courts, did you compare them with other studies that we have to do in the criminal justice system to see what other criminogenic needs these people had? Because the way you're presenting this, you've kind of just put that into a vacuum and that's all you're talking about. But what we've seen is there's a lot more than just that get people into trouble, and you can find some very strong correlations between other types of behavior and other types of substance abuse that will probably give you the same percentages.
So I think there's kind of two parts to that question. So when you look at our rates of brain injury and incarceration, they're very similar to other states. So for example, South Carolina has published quite a bit of data on the prevalence of brain injury in their prison system, and they're showing pretty consistent rates. And the epidemiological data of 60% that I presented earlier is really consistent with what we're seeing overall, including mild. So I think there's nothing unique about Indiana in that respect. But I think the second, maybe I'm wrong, but maybe the second part of your question has to do with etiology or causation. Is that inaccurate?
Mostly, granted, these people have the traumatic brain injuries, but how do you link that to the criminogenic problem that caused the crime without looking at the other criminogenic needs of those individuals? You've got people there, you could probably find a similar correlation between nicotine and tobacco and the people that are committing crimes.
Sure, of course. But as you may well know, correlation doesn't imply causality.
Oh, I understand, but the same thing with what you're saying. You have correlation. How do you show causality?
Right. So I think what's compelling about the brain injury data, at least from my perspective, is in having followed a lot of patients that ended up in the criminal justice system, the data from a research standpoint, the data is showing that 83% of these patients' injuries predated their first interaction with the criminal justice system. I think implies that the brain injury has a certain causal relationship to that. But I think that when that injury occurs, especially in context of the other factors that are criminogenic, like having a criminogenic family or having a history of other adjustment difficulties, then that puts that patient at very significant risk. So looking at it again from a biological, from a psychosocial, and from an environmental perspective, I think if we can use that model to help us understand levels of causation that are driving or predicting that behavior. Does that make sense?
Yeah, but again, we need more data. We in criminal justice will need a stronger causation for us to be able to put them in, and we'll talk about that at our last panel of the day. But we have to work on what we're given when the Supreme Court says you put these courts together and these are the criminogenic needs that you focus on.
Sure. That's terrific.
We need more data or more causality for us to be able to convince the funders to be able to give us the money for this.
No, that's great. So what kind of research would you think would be the most
But
relevant?
again, you have to show us the causality. I mean, that's obviously not my area. But, you know, we get all these reports about the correlation between drug usage, alcohol usage,
Right.
and criminal activity, mental health, and criminal activity.
Right.
And, you know, it's pretty well documented, the reports that we see, and that's why the Supreme Court has said we have drug courts, we have mental health courts, and even with our VA court, the primary functions are for mental health and or substance abuse.
Yeah.
And that's based on what they've seen. I mean, this is the group you have to be able, the state group, so you're going to have to show, yeah, this is a major criminogenic need.
Cool. So I hope this is something we can get into in the panel discussion too then this afternoon, because in following on a case-by-case basis, and maybe the case study this afternoon will be interesting in this respect, on a case-by-case basis, when we examine someone and we do a detailed clinical history and we do neuropsychological testing, and we can put that together then with the medical records and so forth, then I feel like we can make better statements about the causality and the role of the brain injury. But of course, when you start looking at group data, then the multiplicity of factors that drive the ultimate criminal behavior, you don't capture all of those variables in those group studies. Does that make sense?
Yeah.
So individual case studies versus group design methodologies sort of provide different levels of evidence, if you will, or at least from our perspective. I don't know if it does from a judicial perspective.
No, I appreciate that, but again, do you understand what I'm saying as to you're throwing a whole new twist into what we've had to prepare our courts for and our ability to work with problem solving?
Yeah. No, and we're aware of that. And we're not entirely sure what to do with it either yet. Judge Crawford, is that you back there or no?
Training for people that you've conducted for DOC staff and that kind of thing. Is there training available for people who work in the courts or work in different areas about what they do with someone who comes in with a traumatic brain injury, or there's an indication that they have? What kinds of things can be done in order to assist those people?
Well, I can promise you not near enough, number one. And what we have done, I mean, the collaboration that we've had with you and the other judges in the room really represents as much as we have done, and we're significantly appreciative of that, but we're just tiny scratching the surface on this huge issue. When you think about 60% of the people coming through your court have a history of brain injury. So that reality is striking, and issues of causality aside, it's still a huge issue that we need to, and we're just touching on it. Yeah. Yes, sir. Where's the microphone? Yeah, there you go.
Percentage of individuals are in society that have brain injuries that don't end up in the criminal justice system?
A really good question. I don't know that we know that. That's a really good question. I don't know that we know that. I'll have to go back and search. I've never seen a study that's asked that question that way. Yeah, no, that's a really good question, Gordon. Yeah. Thank you. Yes, sir.
Doctor, could you say a few words, please, about the relevance of when in someone's life a brain injury occurs?
Yes. So, okay, well, there's two levels to that, and that's a really good question. So I think the data about brain injury in childhood and adolescence is hugely important for this reason. So we all know that the developing teenage brain is abnormal anyway, right? No, so we know that we acquire social behavior, we acquire comportment, as it's called in my literature. We acquire social comportment, we acquire social rules during late childhood and adolescence. And it's through frontal lobe development and morphology. As we grow through those years, we're learning to regulate our behavior, anticipate the consequences of our behavior, and to use long-term memory to guide our behavior. So at least from a neuropsychological standpoint, we feel that childhood or traumatic brain injury in adolescence or childhood arrests the development of that social comportment that affects mood regulation and affects, at least from a legal perspective, your ability to conform your behavior to what you may know is the law. So it may do that. In adulthood, it's a different issue. So now you have someone who acquired the capacity to regulate their behavior and according to societal norms and expectations, but you may lose it because of the very specific effects of a brain injury. And the case study that we'll do this afternoon had both childhood and adult brain injuries, which puts her at significant risk for criminality. But I think it's very different when you talk about childhood and adolescent brain injury versus adult brain injury. Does that make sense, Judge?
I also, as I walk over to the next speaker, wanted to say that while I do the PACE, I've been co-facilitating the PACE Brain Injury Education Group for the past 3 years. This is our 4th year. We've got people that slipped in the tub when they were 2 years old and never got treated, were knocked out, unconscious. We have people that were, I would say the multitude of people in our groups have not just had one brain injury, they've had many, and they'll talk about concussions, they'll talk about fights, they'll talk about tons of accidents, they'll talk about tons of assaults. So it's really interesting that we have people we've got one guy that literally slipped and fell in the tub when he was a child. We've got people that were shot in the head. We've got people that were beat time and time again. We've got people in multiple accidents. So we've got people who experience brain injury throughout their lifetime as well as at once. And it's interesting when their criminal activities occur. It's also interesting the comorbidities that go with it, such as how they grew up and what their family dynamics were, and the economic status and the setting that they grew up in. We have people whose family are well-rounded physicians that we work with in our groups. Then we have people, of course, whose parents are in jail. So I think we have a multitude of everything at the PACE groups that we run, and it's been a really interesting experience.
Yeah, thank you, Wendy. Yeah, I want to comment about that just a second. Those of you who haven't been at one of these groups, and we've got a couple of folks back there who run these groups, Tony and Jason, at our PACE facility. So what's interesting about this is, and I don't know how consistent or inconsistent this is with their overall behavior, but we've got some guys, or many of the guys that come to the interventions at PACE, and they come to the group treatment and they come to their individual sessions to deal with their brain injury, and we can't get rid of them. They keep coming back and coming back and coming back, and we can't get rid of them. And when they live at Duval, some of these guys are walking. How far is it, Jason? Yeah, so in the dead of winter, they're going to walk to this group treatment. It's completely voluntary, and get there at 4:30 in the afternoon and walk home at night when it's 28 degrees, and we can't. They just keep coming to the intervention, and I think it's because it's the first time that their brain injury has been identified, and they're getting some tools to figure out what to do with it, and so on the flip side of this, I find it compelling how they're responding to the intervention. So, other questions? Oh, sorry, what is PACE? So PACE is a program that provides reentry services to people that are getting released from incarceration or prison. So they may help them get access to health insurance, they may help them get access to transportation, they may help them get access to health care, they may help them get a job coach, help them find employment, they may provide family counseling, all to try and help those people from reoffending. Oh. Yes, ma'am. I would love, yeah, you want to repeat that so everyone hears you?
Do you foresee bringing these programs to level 4 DOC facilities?
I would love to, and I think we desperately need to. This is what we need to discuss at this conference, and is where are we going, and how are we going to sustain this, and what's the best way to do it. We're cutting the edge of this issue. Indiana, there's no precedent out there for us. As I said, Colorado has done some work, Minnesota has done some work, Pennsylvania has done some work in this. We're way ahead of them, and so we're inventing this airplane as we're trying to take off, and so yeah, we're all ears.